Assalamu alaikum. This presentation is on one of the complications of parotid surgery, in which there may be a leak of saliva through the parotid incision or a collection of saliva underneath the parotid skin flap that may mimic an infection or a hematoma. This complication is reported in about 10% of the cases of superficial parotidectomy, a leakage of saliva from the remaining salivary gland tissue that collects beneath the flap, the skin flap of the parotidectomy. And this collection may remain under the skin and form a sialocele, or it may find its way through the parotid incision and becomes a parotid salivary fistula. The real question is this: quite why salivary fistulas and sialoceles are not more common. They just happen in about 10% or so. And given that in most of partial parotidectomy operations, and sometimes even in total parotidectomy operations, there may be a significant volume of residual gland with an extensive cut surface that may continue to secrete saliva and would make the possibility of a sialocele or a fistula a bit more common than this. However, clinically, only 10% would present with this problem, and it's usually mild and self-limited. They almost always settle with conservative management, but this may take 1 to 2 weeks. Sialoceles are not a true cyst. They are not lined by an epithelium. They are just an accumulation of saliva secreted from the residual part of the gland, the leftovers in the parotid wound, which cannot be drained intraorally. This collection of mucoid saliva and the tissues surrounding the parotid gland would give the clinical picture of sialocele, which manifests as a soft swelling over the parotid region. This can be misdiagnosed as a hematoma or an infection, but diagnosis is usually established by aspiration of this cystic swelling, and the aspirate would be a clear fluid that resembles saliva. And if there is still some doubt about the nature of the aspirated fluid, then measuring the amylase content would establish the diagnosis if it is found to be higher than 100,000 units per liter. And the accumulated saliva can find its way to the outside through the parotid skin incision, then it is termed a salivary fistula. And this would be manifested as an external drainage of saliva through the skin. Sometimes a long-standing sialocele may convert to a fistula due to rupture of the skin overlying the sialocele. In parotidectomy, most of the injuries to the saliva drainage system from the parotid is actually intraglandular within the parotid in site A. The Stensen's duct, after the duct emerges from the anterior edge of the parotid, is usually not exposed or identified or ligated during a classic superficial parotidectomy. And duct injuries, the Stensen's duct injuries, are quite rare, and many of these injuries are subclinical or unreported. But there are factors that may increase the risk of duct injury, including extensive fibrosis during, for example, recurrent surgery, or in deep lobe tumors that requires a wider dissection, or when there are anatomical variations in the duct branching, or in malignant parotid tumors. The risk of Stensen's duct, extraglandular duct system injury is increased. The residual parotid tissue after partial parotidectomy or even after some total parotidectomies resume function after the surgery, and the duct system heals up naturally and the saliva continues to flow. So superficial and partial parotidectomies does not abolish the flow of saliva from the operated on gland, but it may reduce it, provided that the duct is not ligated during the surgery. This study had showed that the saliva flow from patients who had either partial or even total parotidectomy is resumed within a week or so. Understandably, there will be a difference in the flow rate between those patients who have a total parotidectomy, in whom the residual salivary flow would be coming from some tissues left over from the total resection or from the accessory parotid gland, and between those patients who only have a partial parotidectomy or a superficial parotidectomy. These patients will have a much more flow compared to the group of patients who had a total parotidectomy. But in both cases, if the duct is not ligated, there will be some residual flow of saliva. The more extensive the surgery, the less the saliva, and there is a good correlation between the gland volume estimated by ultrasound and the residual gland after the surgery and the salivary flow. The more residual gland left, the more the flow. Patient who had a total parotidectomy would have less flow compared to partial parotidectomy, but if the duct is ligated, as sometimes can happen during this parotid surgery, then there will be no flow at all, and this would be followed by spontaneous atrophy of the residual glandular tissue that would gradually just lose its capacity to secrete saliva. The diagnosis is usually easy to establish, and the vast majority of these cases would settle with conservative management. The proviso is that the leak is located from the parenchyma of the parotid rather than from the ductal system, the extraparotid ductal system. If the leak is caused just by the resection of a tumor in the parotid, whether superficial or deep, without injuring or ligating the extraparotid duct, then conservative management would usually be enough to control the leak, the sialocele or the fistula. And this conservative management is basically a pressure dressing to the parotid area. Sometimes anti-sialagogue medications like hyoscine patches can be helpful to reduce the salivary flow. Further reduction can also be achieved if the oral intake is modified, avoiding spicy food and citric drinks and things that would increase the saliva production and flow. In some cases, feeding via nasogastric tube may be also helpful. Simple measures like the pressure dressing and the modification of the diet, hyoscine patches would usually be enough. Sometimes some of the cases would persist, and these will require the next stage, which is Botox injection. If conservative management fails, the next thing to try is Botox A injection into the residual parotid tissue. Preferably, this is done under ultrasound control, where you would identify the residual parotid gland tissue and the duct itself. And by using the ultrasonography, you try to avoid, if it's a color ultrasonography scan, try placing the needle into any nearby vessels, and there are several of these, and also strictly placing the needle into the residual parotid gland would reduce the chance of injecting into a facial nerve branch. The usual dosage would be injecting of 0.1 to 0.2 milliliter of a solution of 25 mouse units in an 0.1 milliliter. So maximum dose would be about 50 mouse units. This would inhibit the presynaptic release of acetylcholine and reduce the parasympathetic activation of the gland and the flow of saliva for up to 6 months, usually somewhere around 3 to 4 months. Now, what to do if the duct is injured during surgery? If this is identified during the operation itself, then immediate intraoperative management would be favorable by a primary repair. This is ideal whenever possible. You try to identify the proximal and the distal stumps of the duct and anastomose these two over a stent or a small catheter. Perhaps injecting also Botox into the residual gland tissue would help the healing by inhibiting salivary flow during the healing phase. A common classification of the parotid duct injuries is based on the site of the injury. It is quite useful because it would be helpful in deciding the management plan according to the site of the injury. The Van Sickels classification classifies the site of the duct injury into 3 unequal parts. The site A is the largest, and this refers to the area of the intraglandular part of the duct branches and ductules within the parotid gland. And then site B is when the Stensen's duct emerge from the anterior edge of the parotid and lies over the masseter muscle until the anterior end of the masseter muscle. So the course of the duct over the masseter muscle is site B. The course of the duct after the anterior end of the masseter muscle, when it starts to pierce the buccal pad of fat and then the buccinator muscle and the oral mucosa, is site C. So these are 3 different unequal sites, and the plan for managing of the injuries would differ according to the individual site. Now the management, if it's a site A injury, this is by far the commonest type of injury to the saliva drainage system from the parotid. In almost all parotid surgery, parotidectomies, apart from total parotidectomy, the interglandular part of the duct would be injured in one or several places. So this is the commonest, but luckily we don't have to do much about it because there's usually very minimal leakage of saliva from injuries to this part of the duct, the intraglandular part, and these leakage are very commonly would settle on their own conservatively within a week or 2 without any eventful complication like a sialocele or a fistula. Even in facial wound injuries, if the parotid area is penetrated by a stab wound, for example, no attempts are made at anastomosing the intraglandular part of the duct, only approximation of the parotid tissue in the area that had been separated by the stab wound, and closure of the fascia on top would prevent further complications. In site B, injuries of the duct, that is to say the part of the parotid duct over the masseter muscle, then if it is just a partial injury, the duct would need to be cannulated and then sutured over the cannula. If it is a complete transaction, like in here, the 2 ends should be brought close together. Again, the duct itself would be cannulated with a fine catheter, and attempts at reanastomosis is done. If the 2 ends cannot be brought together without tension, the area in between can be bridged by, say, a vein graft, like from the saphenous vein, for example. So in these 3 situations, either partial transaction and repair, or complete transaction and reanastomosis, or complete transaction and grafting with a vein. If either these three scenarios could not be achieved, then the decision should be to ligate the proximal and the parotid end of the duct, and this will induce atrophy of the residual parotid tissue and will stop the leak. In Site C injuries, that is to say injuries of the duct after the anterior end of the masseter, the same can be applied. Partial injuries can be repaired over a cannula. Complete transaction can be re-anastomosed, again over a catheter. If the two ends can be approximated easily, they should be anastomosed. If you can not, you can either bridge it with a vein graft, or you can try and implant the proximal end, the parotid end, directly into the oral mucosa and ligate the other end. So these are the scenarios for the Site C types of injury. If there is a doubt about whether there is a duct laceration or not, one easy way of finding this out intraoperatively is to cannulate the parotid duct from the mouth by a 16-gauge intravenous catheter and injecting saline through it. And if you see the saline trickling into the wound bed, then you know that there is a duct injury at the area of the leakage. It was used to inject methylene blue rather than saline into the duct, but this can actually discolor the surgical field and alter the appearance of the nearby facial nerve branches. So saline injection is actually safer. It's easy to find the oral end of the parotid stump. Sometimes it can be difficult to find the parotid end of the parotid duct, and this would require some dissection under magnification. And if there is a transaction, then anastomosis on top of the catheter should be undertaken. Sometimes it can be difficult to identify the parotid end of the duct. You would try to pass the probe or the catheter through the oral end of the duct, and the direction of the probe would usually point to where the proximal stump would be. If it cannot be identified, you can still press on the residual salivary tissue. Applying pressure on these tissue may squeeze out some saliva from the parotid end of the duct and help in identifying the divided proximal end of the duct. When both ends are identified, the duct would be catheterized, and then suturing would be attempted by placing at least 3 sutures with nylon 9O or 10O in 3 different places. The catheter would help in preventing suturing the anterior wall of the duct with the posterior wall of the opposite stump. The use of non-absorbable sutures had actually showed better results than the use of absorbable sutures. Absorbable sutures sometimes leave around some massive fibrosis and scarring that would occlude the very fine caliber of the duct. But what to do in a primary repair if the 2 duct stumps cannot be sutured, because there is a bigger gap in between that cannot be sutured without tension. In this case, you may consider using an autogenous vein graft. And this vein graft would, over the stent or the catheter inside the duct, would bridge the gap. In this case, you would need to make sure that the residual gland tissues are not going to secrete saliva during the healing phase by injecting Botox and giving the patients anti-sialogogues and also antibiotics. The patency of the duct can be checked after 2 weeks or so by either sialography or sialoendoscopy. The other options, if the 2 duct stumps cannot be sutured together, particularly in site C type of injuries, is to try and re-implant the proximal end, the parotid end of the parotid duct into the oral cavity, into a small opening into the mucosa of the oral cavity posterior to the natural papilla, parotid papilla, if there is enough length in the proximal part to reach the oral cavity. But if there isn't, then the other option would be ligation of the proximal end, and this would lead to spontaneous atrophy of the residual parotid tissue and prevent the formation of a sialocele or a parotid fistula. But what happens if the diagnosis of a duct injury is missed during the surgery and would only be diagnosed after the surgery by a week or two, when there is a collection of saliva in the operative field or a leak of the collected saliva through the parotid incision? A collection of saliva in the parotid area after parotidectomy is usually termed a sialocele, and it would typically take about a week or two to form, to have enough saliva in it to be diagnosed clinically. If the saliva can find its way to the outside through the parotid incision, then it is termed a salivary parotid fistula. The prognosis of these two problems would depend on the site of the injury. If it is within the residual gland, then it usually is self-limiting and would heal with conservative treatment. But if it is in site B or C of the Stensen's duct, then some form of management would be required. Also, the prognosis would depend on whether the duct is completely transacted or only a partial puncture of the duct. Are the management options? Conservative management is usually undertaken first, and most of the cases would settle with conservative management of aspiration, sometimes repeated, and pressure dressings, and helped with anticholinergic agents like hyoscine patches and modification of the diet to reduce salivary output. The other option, if the conservative management fails, is to inject Botox into the residual parotid gland tissue, and this will reduce the salivary secretion and promote healing of the glandular drainage system. If this fails, then you are only left with delayed surgical repair with microsurgical techniques to either anastomose divided ducts or graft it, or even divert the duct flow through creating a window posterior to the natural drainage site in the oral cavity. In some rare cases, the sialoceles or the parotid fistula may persist despite all the lines of management already discussed. And in this situation, other techniques may be considered. One of the techniques is total parotidectomy, removal of all the functional parotid tissue to stop the leak. Remembering that total parotidectomy here will be performed in a compromised surgical bed with scar and granulation tissue and a high risk of injury to the facial nerve. One other alternative that was considered in the past was postoperative radiotherapy to the parotid bed to induce fibrosis and atrophy of the residual gland. This has been now abandoned because it would take at least 6 weeks for the course of radiotherapy in order to achieve atrophy of the gland and stopping the parotid production. Plus, of course, radiation would carry some potential for malignant transformation in benign cases. One other technique that was used in refractory cases of salivary fistulas or sialoceles is tympanic neurectomy, aiming at disrupting the tympanic nerve, carrying the parasympathetic secretory fibers to the residual parotid tissue. and this would hopefully reduce the salivary flow and help with closure of the fistula or resorption of the sialocele. However, the results were disappointing, probably because with time there is a process of re-innervation of this residual glandular tissue, and although this technique was used in the past, the method tends to be abandoned due to its short-term action and poor results. There would be few situations during parotid surgery when we'd need to consider duct ligation during the surgery, the initial surgery itself. This is selective ligation of the duct. It's not a standard step of the most parotidectomy operations. A decision of duct ligation may be considered in total parotidectomy when most or all of the glandular tissue removed. Ligation then may reduce any persistent salivary leakage and sialocele formation. May also be considered in recurrent parotid surgery because of the scarred anatomy and the higher risk of postoperative salivary fistula. And also it should be considered when malignancy involving the duct or near the duct, when direct duct invasion can be an issue. There may be a need for oncological clearance and duct excision or ligation then becomes necessary. By this, we come to the end of this presentation on the post-parotidectomy sialoceles or parotid fistula. Assalamu alaikum.